Yeah, next I invite the next speaker to present the case on surgically induced necrotizing scleritis, a nightmare to strabismologists. Dr. Aparna.
Good morning, all. I'm presenting surgically induced necrotizing scleritis, or SINS, a nightmare to dermatologists. It is a severe inflammation of sclera seen post-operatively with a rapid devastating course leading to visual loss if not recognized timely and treated. These are the two main groups of risk factors for the development of SINS. Among the surgeries, pterygium excision and cataract surgery is the most commonly reported. Number of cases reported in case of squint after squint are very less. After the surgical ocular trauma, it can increase the collagenous lytic activity, which can lead to collagen degradation and vascular disruption, which can activate the complement system and can lead to scleral necrosis. Always rule out the main differential diagnosis, that is the postoperative infection. We have a case series of 3 patients. First is a 7-year-old girl with infantile ET. She had a mild developmental delay. Her intraoperative period was very uneventful. Post-operatively, at 1 week, she developed watering, discharge, left eye pain, decreased vision, chemosis, and bulging over the medial rectus and lateral rectus muscle. We started her on IV antibiotics. Her cultures were negative. She showed no improvement. We resorted to IV steroids and topical steroids. She started showing improvement. Her hematological and systemic disease evaluation were all negative. Re-exploration under GA showed choroidal bulge at reinsertion site of lateral rectus. We considered scleral patch, but the patient on subsequent visits showed great improvement. Second is a 63-year-old male, no history of comorbidities. He underwent combined SICS plus squint surgery. On 1 week post-op, he developed severe pain, discharge, defective vision, chemosis, scleral abscess over the medial rectus insertion, and 360-degree choroidal detachment. His culture and sensitivity showed Streptococcus pneumoniae. We thought it as infective and we started him on IV antibiotics, but no response was noted and we resorted to IV steroids followed by tapering oral steroids. He showed drastic improvement. The third case was also a 62-year-old male, hypertensive. He underwent combined phaco plus squint surgery. At 2 weeks of post-op, he also developed the similar complaints as to the previous patient. He also had chemosis, abscess at medial rectus, and 360-degree choroidal detachment. But in his case, at 2 weeks, we noted psoriatic patches over the dorsum of hand. On further history taking, he revealed that he had past history of psoriasis, for which treatment was stopped. So we restarted the psoriasis treatment plus steroid treatment and he showed complete resolution. According to literature, early case reports are seen in patients with multiple surgeries and it is suspected to have underlying immune mediated process and lateral rectus are commonly involved due to less blood supply. But in our case, all our case reports were in 2 weeks, no history of multiple surgery, and only one of our case had history of autoimmune disease, and all our cases had involvement near medial rectus. Tamhankar et al. Reported atypical necrotizing scleritis in an 88-year-old woman. She also developed over medial rectus with no history of any autoimmune disease. There is no time limit for the development of surgically induced necrotizing scleritis. The longest, even after 51 years, it has been reported. Initial high-dose systemic steroid or pulse therapy followed by maintenance therapy has been proven to the early healing in SINS, and surgical debridement, contact lens, tectonic scleral patch can be considered in cases when there is no response to steroid therapy. Our case series highlights that early recognition and management of SINS is necessary, and we should always emphasize on the screening of associated systemic diseases in strabismus. Thank you.
Good presentation, doctor. Can you tell me out of how many cases of squint surgeries you got 3 necrotizing scleritis? Means large. How many squint surgeries you usually do? Out of which, how much got this kind
This
of?
is over a period of 14 years, madam.
Oh, okay.
The first case was actually 14 years back it has developed. But I think it was very rare. Maybe I can say 1 in 1,000 or like that only we could get. Because
And
all
what is your routine of putting steroids after squint surgery? If it is due to large amount of steroids postoperatively, can lead to necrotizing scleritis. How much steroids do you give locally after strabismus
we
surgery?
usually give weekly tapering dose. We start from 4 times a day. 4, 3, 2, 1 line.
Routine
Routinely
strabismus.
we
Only 4 times a day.
4 times a day we give.
Okay.
We don't.
Do you think any other intraoperative steps could have led to this, like say excessive cautery or excessive drying up of the sclera?
Actually, in
So-
these 3 cases, we haven't used much cautery. Only for the SICS patient at the not at the site of squint surgery, we have used cautery. So in these 3 cases, we have not used cautery. And
And-
all the intraoperative were similar to all other cases. None was uneventful.
And the post-operative alignment was fine.
Patients were actually post-operative alignment was fine.
Thank you. Thank you.
So next, excuse. That's that.